It's my pleasure to welcome Dr. Gurumurthy, Senior Consultant, Ganga Hospital, Coimbatore. Sir was faculty for Regional Anesthesia Fellowship course for more than 15 years, and he was the invited faculty for many regional anesthesia workshops. And Sir has delivered webinar lecture in World Congress of Anesthesia, and he has done more than 15 publications in regional anesthesia. I welcome you on stage, sir. And it's my pleasure to welcome Dr. Subramanian, Fellowship in Advanced Regional Anesthesia and Trauma, Associate Consultant, Rela Hospital and Medical Center, Chennai. Sir is a faculty member in CRAB, ADRA, Research Academic Board, and he was the invited faculty in a workshop 2024 Hyderabad and 2025 Amritsar. And he's known for his USG guided regional anesthesia workshop faculty conducted in Pondicherry in the year 2024 and in Tamil Nadu, Erode 2025. On behalf of Preeti Hospital, we welcome you, sir.
Very good morning to all of you. At the outset, I would like to thank for this opportunity. Especially I want to thank Dr. Balaji and Dr. Suresh for their meticulous efforts. I will move to my volunteer scanning. First of all, the talk is volunteer scanning on brachial plexus from root to branches. Though we say root, it is not root always we see. What we see is ventral rami only. So dorsal rami goes to back side, it supplies the other area. So our area of interest in brachial plexus is more of, it is ventral rami only. So ventral rami, then that is colloquially we call root, then trunk, division, cord, then finally branches. So usually give different level of block like interscalene block, that is either root or trunk we cover. Then we come to the supraclavicular block, otherwise it is called subclavian perivascular block. There we deal with either trunk or divisions. Then we come below the clavicle, costoclavicular block. There we deal with more of cords only. There won't be any divisions. And further moving lateral, below the clavicle, that is infraclavicular block. There also cords are little more separated. Then finally, axillary area. Though it is called axillary brachial plexus, there we see individual nerve elements only. Then further we move away, that is mid-humeral level. There we see individual branches. So then next level is wrist and elbow. Obviously we see individual branches. So is it necessary to scan root to individual branch? There are some situations, plenty of anatomical variations are there. Every patient is different. So though we think whatever we say, that traffic light sign in interscalene groove or bunch of grapes in subclavian perivascular area, it may not be the same in every patient. So unless we go systematically do scan in every patient, we might miss or we might go into the wrong area and we might miss all the elements of brachial plexus, and sometimes we might end up in breaching the safety of the nerve blocks also. Invariably, majority of the time we choose this high frequency linear probe for all thin patients, but especially below the clavicle block. Even in obese patients, this high frequency linear probe is enough for above the clavicle block. But if you go below the clavicle block, though we have to look and struggle in obese patients with this linear probe, if you choose the curve linear probe, many times our job is easy. So any obese patient comes, better to choose scout scanning. And scout scanning we have to do with either first linear probe. Obviously, if you face difficulty in obese patients, muscular patients, better to choose the curve linear probe, and you have to reorient ourselves, then give the block. Especially for costoclavicular and infraclavicular, we have to use curve linear probe. So next, I will move on to position of the patient. So usually we choose supine position, but in in-plane technique, sometimes we have to choose, even for supraclavicular block and interscalene block, we have to choose lateral position. The other preferred position is head and up position, probably 30 degree up, especially for interscreen scanning and in-plane technique, it is very useful. Sometimes depends on the patient discomfort also, because suppose fracture is there, whatever position is comfortable we have to keep. Majority of the time we keep supine position, we stand in front, head end of the patient, and preferably ergonomic should be very good. I would like to always sit and give the block, preferably adjust the table according to the comfort, and patient is supine, and for first we'll start with above the clavicle area scanning. So patient limb is adducted and he is keeping resting over the chest, and I'm telling to turn the head towards the other side. Then we have to orient the probe also. So this marker is over the blue area, that is going to be in the towards the chest. Okay, so now I am keeping the probe. Always, why this root to branch scanning? The idea is to not to miss, or if any difficulty you face, you can come back proximally and distally. Sometimes if it is difficult in the proximal area, you come to distal and sweep and see. Suppose if you have difficulty in proximal area, you come to distal and again go there in the proximal area and scan. So I will move on to this proper scanning. First, anybody can easily identify, that is, I am keeping the probe over the just above the clavicle in the supraclavicular fossa. The pulsating structure, what we see is subclavian artery. The hyperechoic line, what we see is first rib below the subclavian artery. Then we see bunch of grapes, that are brachial plexus elements, mainly trunks and divisions. Then I will slowly move on to cephalad. I am tilting the probe cephalad, and two big muscles we are seeing on either side of the interscreen groove, this area called. So if you go medially, we can see sternocleidomastoid muscle, and if I am giving pressure, I could occlude or compress the internal jugular vein. The next pulsating structure, that is carotid. Next to carotid, we can see one different homogeneous structure, that is thyroid. Since I am keeping the probe more medially towards the midline of the neck, now I am coming laterally and again trying to focus on our area of interest, that is interscalene groove between the two scalene muscles. So the muscle which is medially is there, it is anterior scalene. So which is next is we see that brachial plexus elements. Then the other muscle what we see is middle scalene. So we all know brachial plexus is formed by from C5 ventral rami to T1. But sometimes, as book says, prefixed and postfixed can be there, but those things are very difficult to differentiate. Otherwise, if you scan up to C4, you might be able to trace. So now we'll start with elements of brachial plexus from again subclavian artery, and next to that we are seeing that bunch of grapes, that is roots and sorry, here we don't see roots, here we see trunks and divisions. As we move on, we see elements of brachial plexus in the interscalene groove. So there are some specific features how to identify C5, C6, C7. In C7, everywhere you have to look for the transverse process appearance to find out the level. Suppose C7 has unique feature, unique sonomorphology, and C5 has unique sonomorphology, even C6 has unique sonomorphology. So now if I scan medially and laterally, first we will start with C5. The structure, probably every root or ventral rami which comes out of vertebral foramen, from there we are going to identify. So now you can see one structure which is trying to go in between two hyperechoic area. The structure that is C7 now root. So if you see, there is one next to the C7 now root, one prominent shadow, that is posterior tubercle. This is posterior tubercle. So transverse process has two components, anterior and posterior tubercle. Based on this, we are going to identify the level of the nerve root. And here, prominent, this is called posterior tubercle, prominent. And if you move on, that tubercle is missing there, or it is very rudimentary, small. But in that place, you can see some other component. So these are all the pulsating vertebral artery and vein. So previously there was a lot of bad reports before ultrasound era, especially bad neurological injuries happened because of injury to this vertebral artery. So always we have to take care of that. Look for these vessels so that we can identify major neurological damage even to the brain also. So we identified C7. Now, see, always the moment it comes out, usually it divides. So that is also important. See, unless we know the division, it is easily to miss and misidentify. Like sometimes we think that is individual component like that. So I will come to that later again. So now I will move on again. It is C7. I described. It is going inside the foramen and coming out. Now I will move the probe cranially, and here we look for another transverse process components, that is the whatever anterior component is either prominent or it is bigger. Majority of the time it is prominent. So what now we can see one component is coming out and going inside. Okay. Next to that, medially, if you see that prominent Chesapeake tubercle, that is C6 anterior tubercle. Relatively, that other posterior tubercle is relatively smaller. Okay. Now we found out C5, C6, sorry. C6 is dividing the moment it comes out. Here also the dividing we have to note it down. Then if we move the probe even more cranially, again we can see one component is coming and going out. That nerve component is C5. Here if you see that tubercle, anterior tubercle and posterior tubercle, almost they are in equal size, which is the usually differentiating features between C6 and C7. And usually C5 is single. So if you see C5, it is it is single. It is not like other component, it is getting divided. And at the same time, lot of anatomical variations in C5. So C5, if you trace, imagine this area, if I am keeping the probe like this, if you miss C5, then we might think that whatever we are seeing here, freeze it, freeze, yes. So previously it is called something like traffic light sign or stop light sign. So this is, people think sometime if you are not systematically scanning and tracing, People might think this is C5, the next one is C6, next one is C7, and they might think this is C8 and T1. This can be easily misinterpreted like that. If you are not followed properly where the C6 comes out of vertebral foramen, and you might easily miss these two components of C6 and take it as this as C6, and this other component of C6 can be misinterpreted as C7 unless you are not very careful. At the same time, the same confusion can come here also. C7 has two components. This we can identify as C8 and T1. So it is very important to scan systematically and look for the individual component which comes out of vertebral foramen. Now we have seen some of the anatomical variations also. Here also, if you see, there is a lot of gap. The idea of systematic scanning is there is so much of gap between C5 and C6 component. So if you go cranially move the probe, the C5 component is moving and going towards the anterior superior surface of anterior scalene. And there is a lot of gap, or sometimes depends on the place, there is a gap between the C5 and C6. So one, we identified C5 is little away, and it is single, and now we have to identify trunk. We all know upper trunk is formed by C5 and C6. So after tracing individual component, I will trace down and come and show the C5 first. The neural element, whatever you are seeing first, it is C5. And next one we are seeing is here we could see that so this is C5, these two components are C6. If I come down, they are merging together. Now it has formed upper trunk. If you see, three components are here. If you closely see, now it is started dividing. Now you have to identify one more muscle, that is omohyoid muscle here. Then we can understand that upper trunk in a better way. So why identifying omohyoid is important? Just below the omohyoid, that proximal most component of upper trunk, that is suprascapular nerve, it comes below the omohyoid. So the idea of giving upper trunk block is to reduce the complications of phrenic nerve palsy. So we want to go away from phrenic nerve. That is, if you give block in this groove, why upper trunk? Because the more and more you move away from phrenic nerve, so phrenic nerve lies over the anterior surface of anterior scalene. If you move the neural elements further down, the chance of getting phrenic nerve palsy is less. Definitely the incidence is less when you give upper trunk. So now this is the C5, C6 combined together forms upper trunk. Upper trunk, the first important nerve which we are tracking is suprascapular nerve. Again, if you go and see cranially move the probe, it is coming and forming the upper trunk. There is something called SPA also, they say. SPA appearance is that the marker is there over the suprascapular nerve. Then P stands for posterior division of upper trunk. The other component is anterior division. So just after finishing upper trunk, I will come to this other again proximal area where we see interscalene where we give interscalene block. We have to look for again muscles of this the two important muscles, that is anterior scalene and middle scalene. In middle scalene, you have to see the middle scalene substance carefully. There are some hyperechoic areas are seen in the middle scalene, probably one above and one below. Two lines are there. These two lines, if you trace, they are coming and going in from the interscalene groove and coming out. They are the elements of this dorsal scapular nerve and long thoracic nerve. Why it is important? If you are not very careful, especially if you are giving interscalene block from in-plane technique, if you come from this side towards neural element, there is a chance of injuring these neural elements. Though it is more of theoretical, but every book says if you go and damage, especially with a direct needle injury, needle to nerve contact injury, chances are very high. So now we have finished upper trunk. So roots, now it has become trunk. So this is upper trunk, and this one is middle trunk is formed by C7. Yes. Now we have to look for the distal component, that is C8. So this is middle trunk, and if you look for here one hyperechoic line, that is first rib. In fact, they say it is first rib and T1 transverse process bony complex, it is called T1 transverse process and first rib complex. Here just above that, if you see one element, that is C8. Whether it is C8 or along with T1, that we'll come to know by seeing the other scanning little more towards, if I sweep the probe little more towards the thorax, probably that element is coming out and going inside. Now I'll move further more distal, like where we give supraclavicular block. Some elements are coming out of thoracic cavity and reaching. So identifying the T1 is possible in thin patients and around 40 to 60% of the people. So if you see some component is moving out of thoracic cavity, and you can see pleura here, and one component is moving out of thoracic cavity and coming and joining this our regular interscalene groove area. So probably this is T1 and C8. So if you want to give selective trunk block, so you have to identify the formation of upper trunk and middle trunk and finally lower trunk here. So in this, by doing this scanning, this level, we can identify both. We can give upper trunk, middle trunk, and lower trunk. If you don't want to miss, why we have to scan really T1 is necessary or not? Because T1 forms the important part of the brachial plexus, especially it covers radial nerve and uh, distal hand surgery is there. T1 component is very important. So why we have to identify T1 is there are two reasons. One is not to miss when you operate or give anesthesia for a distal forearm and hand surgeries. Another reason is there are some anatomical variation. See, this is biology is very kind enough to give the very thin patient. This may not be in every case. Suppose there are some patients where now we can see brachial plexus elements only over the posterolateral aspects. There are some patients might get component brachial plexus component here also. Very rarely T1 need not come next to the lateral to the subclavian artery. Rarely now we know the T1 component is coming out of thoracic cavity and reaching here. Suppose if the component doesn't comes, rarely it moves to the opposite side also. Unless we identify this, there is a very high chance of missing T1 and we might end up in failure of either selective trunk block or even subclavian perivascular block also. Now, subclavian perivascular block or supraclavicular block it is routinely called. So I will move on there. Here we see mainly trunks and divisions. So if you come here, we can see upper trunk. So this area corresponds to upper trunk. So this is upper trunk area. It is coming and staying in the superficial area next to the omoid. This is upper trunk. So this area is called, these neural elements are called middle trunk and corner pocket. This area is called corner pocket. Okay, why corner pocket is important? There was a situation in PNS also or in the initial ages of ultrasound. People used to give combined suprascapular nerve, supraclavicular nerve as a block, supraclavicular block and axillary block. Even now, sometimes people don't want to miss any component. Simply give supraclavicular and axillary. The now recently after refinement of so much of ultrasound scanning, now people are concentrating only on supraclavicular block because if you miss this corner pocket, there the lower divisions or lower trunk is there, this area, and if you don't identify T1, then T1 may not be seen in all patients, but we should be able to give this corner pocket area. Otherwise, the chance of lower division or lower trunk component can be easily missed in supraclavicular block. Okay, so here how we are keeping the probe, it is very important. Even this positioning, I have kept the pillow little below the shoulder. That is also more important. So here identifying pleura also very important. If you are little tilting the probe, pleura is there next to the first rib. So easily when we handling our needle, it can come and touch the pleura. So we have to identify the pleura. And if you want to, either you can avoid the pleura by keeping the probe like this, or you have to move away and give the block. So now Again, I will revise the anatomy once again and then move on to below the clavicle. So we know the elements of brachial plexus, posterolateral to the artery. So this is where we give supraclavicular block, and I will move. This is a place between the two interscreen muscles. Here it is very important to identify the individual nerve root or ventral rami. So we have to identify the transverse process unique morphology, which starts from C7 has unique morphology and C6 has unique morphology. So this is what I was trying to tell, that the transverse process of C7, which is posterior tubercle, which is there. Anterior tubercle is very much rudimentary, or it is absent. In that place you see vertebral vessels. And next level, C6 component. C6 we see prominent chestnut tubercle. C6 is coming out and it is immediately dividing. That is a very important point we have to note. So it is not again C7, it is C6 only dividing into two. And further move cranially, we can identify C5, which is going, here anterior tubercle, posterior tubercle both are equal in size. Further cranially after moving. So again better to trace the C5 because C5 component is moving and going further away. So one of the important advantage of upper trunk is we will not usually miss unless if you trace properly we will not miss the C5. Then we have to look for the suprascapular branch dividing. It is going below the omohyoid belly. Yes. So we can trace suprascapular. Now again this is all the components, especially C8 to some extent T1 also it is visible. Here two components are there. Probably the one component which is coming out of thorax is T1 and trying to form C8 T1 here. So now I will move on to below the clavicle. So below the clavicle requirement is to abduct the arm, but in fracture patients sometimes it is not possible, but the more and more you abduct it is going to be easy. So either you can give minimal analgesia like fentanyl, then you can move the arm abducting arm, you can move it abducted, or the other option is you can compare the scanning also. Now also I will do the scanning in a first adducted position, then we will move on to the position which is favorable for us, that is arm abducted position, then we will do the scan. So I will start from clavicle, then I slip the probe just below the clavicle. So what we see is some vessels. This is not very clear. So the moment vessel is not clear, so vessel is not clear. So the pulsating structure, my pointer is towards medial side. So pulsating structure is axillary artery, first portion. Then axillary vein you can see. Now I'll move on to lateral side and try to see the brachial plexus elements, but it is difficult. If I move the start moving abducting, see you can see the neural elements. Even if I have difficulty in keeping the probe also in adducted position. The moment I open the abduct the arm, the neural elements are very clear. So here it is very important to scan the vessels, then muscles. So the muscle first what we see is pectoralis major. Then we look for one important muscle, that is subclavius. Before going into subclavius, we are seeing that axillary vein getting drained by another vein, that is cephalic vein. So if you are doing the scan with the level where the cephalic vein is draining, our scanning is not even proximal, not enough. Two simple ways to identify this is first I am going to scan costoclavicular area. To identify in this costoclavicular area, we see only cords. So in cords, if you want to see cords properly, don't look for cords. You have to look for three structures. That is the superficial structure next to the skin and subcutaneous area. That is pectoralis major. Then the next structure is subclavius muscle. Then you have to look for one more structure, that is serratus anterior, facing to the depth. So if you are able to see the serratus anterior muscle, and which is lying over the top of the ribs, and if you see serratus anterior and pectoralis major and subclavius muscle, then usually we see the cords in a proper manner. So imagine if you are scanning little more down, then the components are little altered. So the idea is to see these three muscles, that is pectoralis major and subclavius, then serratus anterior. If you see, then you can see the cords which is very much clustered. Okay, clustered means previously we were thinking like selective trunk block, those area is called spinal anesthesia of upper limb. Now in recent update they are telling this costoclavicular block is the most clustered area of cords, most clustered area of brachial plexus. So this is called spinal anesthesia of upper limb. So here if you see two components, anterior component and one posterior component. So anterior component is lateral cord. If you see here, it is medial cord. Sometimes it is difficult to differentiate between medial cord and posterior cord. So how we can identify medial cord and we can posterior cord? Further, if you move away, so whatever we scanned, it is called medial infraclavicular fossa. Now if we move the probe little lateral and try to follow the neural elements, so here we scanned for costoclavicular block. You have to really tilt the probe. You have to keep it along the curvature of clavicle for costoclavicular block. That is more important. Then you should be able to see all three muscles. Then I am moving the probe lateral and rotating the probe and trying to come. Now we can see here we see two muscles, that is pectoralis major, the first muscle immediately after the skin and subcutaneous area. The next muscle is pectoralis minor. If you see the pulsating structure, that is distal part of the axillary artery. Then the other vessel is axillary vein. Here you can see neural elements are surrounding the axillary artery. So if you go in between that, if you try to see in between the two artery and axillary artery and axillary vein, that is in relation. Here the chords are called named according to the relationship to the artery, axillary artery. So in between the axillary artery and the axillary vein, we see medial cord is seen between the axillary artery and vein, and if you see just below the artery, it is posterior cord. Lateral cord is lateral to the artery. So if you trace the cords again towards the this is our costoclavicular component. So costoclavicular component, again rotating the probe, and sometimes it is difficult to identify the cords in infraclavicular area. Either we can move lateral and medially we can differentiate. If you move laterally, the cords are well differentiated. Previously people were thinking that cords are easily visible in the infraclavicular area, but after seeing this costoclavicular block, which is the latest spinal anesthesia of hand or arm, you can say. So now this much clustering is not there in the infraclavicular area. If you see, cords are you have to rotate the probe and keep the probe vertically, not in a transverse manner, for infraclavicular brachial plexus identification. So now, so the idea of giving costoclavicular and costoclavicular, the idea of giving one is the components are very dense, and the other idea is to move further away from phrenic nerve. So some of the latest literature and our personal experience, if you give costoclavicular block, it covers even for shoulder surgery, even for proximal humerus fractures. Only it is not same for all the procedures and all the depends on the patient. This one actually patient obesity. Suppose if the patient is thin, COPD compromised, if you want to do proximal humerus fractures, it is possible to infiltrate the skin and you can do the costoclavicular block, which will cover up to the trunk, upper trunk also it will cover. Even if you give local anesthetic drug in the costoclavicular area, slowly it spreads to the upper trunk area. But if is there any possibility of avoiding phrenic nerve block completely in costoclavicular? It is not so. Even costoclavicular block has something called chimney effect. So even if you give drug in the costoclavicular area, the drug moves towards upper trunk and it affects the phrenic nerve, especially in a compromised patient, they develop breathing difficulty. So if you want to avoid almost near total, if you want to avoid phrenic nerve, better to go for the infraclavicular block. So now I will move on to axillary area. So So I'll move the probe from my my pointer is vertically I'm holding. I'll move towards the axilla. As I told you before, if you have difficulty in scanning this costoclavicular area, especially in a muscular patient, we have to choose the curvilinear probe in obese patients. So now I'll move on to axillary area. The cords are, we are following the cords along with vessels. Now we have to look for the axillary vessels. So depth we can reduce. You can see one pulsating artery. Here also plenty of anatomical variations are possible. Sometimes we see 2 axillary veins, sometimes 3, rarely we see 4 veins also. If you see here, it is very difficult to look for the individual component of like which is ulnar now, which is median now, or which is radian now. It is difficult to identify just like that. So again, whenever we have any difficulty, we have to go for the distal scanning and come towards the axillary area. So I will describe the anatomy. So what we are seeing is that bony structure here, humerus, humeral head, and conjoint tendon. So we are seeing conjoint tendon and muscles is pointing out. That is latissimus dorsi and teres major. So the pulsating structure is axillary artery. So next we will probably easy identification of that muscle component, that is biceps. This is biceps. So the below muscle is coracobrachialis. So in between you can see some braid structure, that is musculocutaneous nerve. So usually we identify musculocutaneous nerve in the initial area, the initial scan, because there are some patients musculocutaneous nerve has different, it has anatomical, lot of anatomical variation. It may be, rarely it might be absent, or it might be very near to the median nerve area, or it might be a plexus along with median nerve. So whenever we have difficulty in identifying this, our median nerve, ulnar nerve, something called traceback technique, what I am going to show. So everyone, we are all aware that next to the medial epicondyle, here, this is the medial epicondyle. So here next to that we have ulnar nerve. Everyone, even for very obese patient, we can palpate and we can identify. So this is the medial epicondyle, that bony shadow. So the bony shadow, one just below the skin, we are seeing one structure, that is ulnar nerve. So in fact, if you trace very close, it is coming very near to the, moving along the medial epicondyle. Now I am tracing back to proximal area. So just below the skin and brachial fascia, this honeycomb appearance, that is ulnar nerve. I am moving the probe towards axillary area. So just we have to follow the ulnar nerve. So now it is coming near to the 2 o'clock position, like that. Again I will trace it back. If I move again distally, that nerve component which is moving just in the, it is running below the brachial fascia and the subcutaneous tissues, subcutaneous fat. It is coming near to the medial epicondyle. So it is very easy to identify the ulnar nerve like this. While tracing ulnar nerve, we are seeing the humeral head also. And if you see the humeral head, and one more component is coming, and this nerve component is coming and attaching along with the radial nerve, along with this next to the ulna. Now we are seeing one more component coming from the humerus area and joining. That is radial nerve. Okay. I'll come to radial nerve again from distal. Usually for all the blocks, majority of the blocks, especially for axillary and costoclavicular, infraclavicular, we keep the arm abducted. Only one situation we need abduction, and we have to keep the arm or chest, hand over the chest wall, is to trace the radial nerve. So here we have lateral epicondyle. So just I am keeping the probe over the lateral epicondyle. Here we see some neural component next to the humerus, which is even dividing also. So this is where the proximal radial nerve getting divided into two component. That is, one is radial nerve main branch and posterior cutaneous nerve. So here we can see dividing of this main radial nerve, and which something is going near to the subcutaneous area, that is posterior cutaneous nerve of thigh. So if you posterior cutaneous nerve of forearm. So if you want to block the radial nerve, especially if you want block the posterior cutaneous nerve of forearm, then it's better to block in this area, mid-humeral. So unless you block here, we are going to miss the posterior cutaneous nerve of forearm here itself. If you go move distally, posterior cutaneous nerve of forearm is getting separated. So then I will follow this radial nerve main component. It is going next to the radial groove. You can see some pulsating component also. So that is profunda brachial artery, or otherwise called radial collateral artery. So probably again we'll come here. So we had a difficulty in seeing the ulnar nerve clearly, and we know how to trace it from elbow. Now we had again difficulty in tracing the radial nerve. So whenever we have a difficulty in scanning radial nerve, we have to go for a proximal to distal scan. If you scan distally next to the radial groove, one nerve component is seen, which will slowly, they say it falls over the humerus. So if you trace it back, it comes and occupies almost like a 6 o'clock position. Default back coming in. So now we are seeing radial nerve is coming and entering into the radial groove in the humerus. Okay, now I will move on to median nerve scanning. So medial nerve scanning, again we can trace it from axillary area. Sometimes we find it difficult to trace where is median nerve. So So easy identification or how to make it very easy is you have to start from elbow. So every one of us know where is the brachial artery. So if you scan brachial artery, so my marker is towards medial side. So any nerve structure you are able to see next to the brachial artery, medial to the brachial artery. So I am keeping the probe over the elbow. So the honeycomb appearance which is next to the pulsating brachial artery is median now. If I am tracing it towards the axilla, so it is again something called the famous saying is brachial artery, and that brachial artery is median nerve is married to the brachial artery, so it always with the artery only from elbow. If you see, I am scanning again distally. So median now is exactly in the 11 o'clock position of the artery. Now the position might be little different, but if you clockwise, but it is always next to the, though it might be with the variable clockwise position, but it is next to the brachial artery always up to the axillary artery. Sorry. So again one second I will trace from now my marker is towards my side, that is lateral side. So this is the median now. If we trace the median now, it is almost lying over the 12 o'clock position, and we can easily identify. Okay. So we'll try to trace musculocutaneous now, but usually it pierces the coraca brachialis and disappears. So it has become a lateral cutaneous nerve of forearm, but to some extent only you can scan the between biceps and coraca brachialis. We can see the musculocutaneous nerve, and we can trace lateral. So it is difficult to scan the nerve. Musculocutaneous is near to the wrist. So if you want to give block for a shoulder and proximal humerus, preferable block is interscalene block. If you want to avoid phrenic nerve or lesser the chance of phrenic nerve, better to go for a upper trunk block. But if you want to avoid further incidence of phrenic nerve, better to go for a costoclavicular block. If you want to totally nullify the phrenic nerve involvement, in fact you have to choose infraclavicular. Obviously we move away from main component like true root and trunk. The more and more we distal we go. Now I think we'll move on below the wrist and below the wrist. Exactly at the wrist, we don't give block because a lot of vessels are there, and sometimes difficulty in identifying the nerves also. But there is a trick and tip also for that also it is there. But preferable area of block is either interscalene or subclavian perivascular area or costoclavicular or infraclavicular, then axillary. Next preferred area is mid-humeral. Mid-humeral because radial nerve not yet divided. Mid-humeral means many times we think it is mid-humeral. No, it is not exactly mid-humeral. Sometimes it is upper 1/3 and lower 2/3 of the arm. So it is not exactly in the mid-humeral area. Then below the mid-humeral level, I think radial nerve divides. That you have to keep it in mind. Very important point. Ulnar and median usually divides. It doesn't have any branches in the arm. So that we can block even at the elbow or below elbow level also. Especially if you want forearm Mid-humeral level, if you block, I think below the elbow we can cover entirely muscles, skin, everything we can cover. Only thing what we are missing here is something called medial cutaneous nerve of forearm. Medial cutaneous nerve of forearm, which is the direct branch of axillary brachial plexus. So if you scan here, we have scanned all the major nerves like ulnar, radial, and musculocutaneous, then median. Now we have to look for the conjoint tendon. So conjoint tendon, if you look, if you go even more lateral, there is a area just above the conjoint tendon where our marker is there. This is where we see medial cutaneous nerve of arm and intercostobrachial nerve. So the other way of scanning medial cutaneous nerve, another important component of brachial plexus itself, that is all the forearm, that especially lateral aspect of the forearm is branch of musculocutaneous nerve. Medial aspect of the forearm, it is posterior aspect is radial nerve. Medial aspect is it is a direct branch of brachial plexus, cutaneous nerve. So it is difficult to trace the nerve, or what you can say, next to the ulnar it lies usually. We know ulnar now where it is, where is ulnar. So again I'll just to revise, I'll come back from medial epicondyle area. So if you trace the ulnar now in the subcutaneous area and come near to the axillary artery, if you give the drug around the ulnar now, usually it takes care of medial cutaneous nerve of forearm also. So the other way of doing it, sometimes you have to look for the basilic vein and giving. If possible, you can look for the basilic vein and give. Okay. And now we'll move on to proper mid forearm and like one of the important area is mid humeral. Again, important area in the forearm is mid forearm. So mid forearm, there are some advantages. You can see the median now very easily. So there is one area, this is a mid forearm. We can see one hyperechoic structure, that is median now. So marker is away from me, and if you look for the muscle which is above the median now is flexor digitorum superficialis. If you look for the muscle below the median now is flexor digitorum profundus. So if you trace the median now from here, almost it is nicely seen, and it is coming next to the brachial artery. Okay. It is coming next to the brachial artery. It is medial to the brachial artery. Again I am tracing the median now. So it is coming and lying between the two muscles, that is flexor digitorum superficialis and flexor digitorum profundus. Here we get one panoramic view. If you move the probe laterally, we see one pulsating artery, that is ulnar artery. One marker is medial. So now if we trace the ulnar artery, then one neural component you see, that is ulnar nerve. So if you want to trace the ulnar nerve, so from the wrist you can trace the ulnar artery, the pulsating structure. Here we don't see individual nerves or very clearly. You see more of tendons only. Everywhere we see lot of tendons. We don't see any muscles here. But if you go to ulnar artery and trace it proximally, the nerve component, hypoechoic honeycomb appearance, which is just traveling next to the ulnar artery, that is ulnar nerve. So I'll get the panoramic view. That panoramic view is for both median and ulna. So what is this panoramic view? You can see three important structures and two important muscles. The muscle component, like we know, that is between flexor digitorum superficialis and flexor digitorum profundus. Flexor digitorum profundus is a bigger muscle. It covers both. It is lying in the anterior to the, posterior to the both ulnar nerve and median nerve. The entire muscle, is flexor digitorum profundus. This is the panoramic view I told. So this is median now. Here we can see flexor digitorum superficialis. If you see the muscle which is here is flexor carpi ulnaris. So this is ulnar now. So ulnar artery also you can see. So this is a view called panoramic view, which covers ulnar artery, ulnar nerve, and two muscles and median nerve here. Okay. So already I told radial nerve, it's better to block. Especially if you want to cover the posterior aspect of the forearm, you have to block above the elbow in the mid-humeral level. But now we'll try to trace radial nerve in the forearm. Forearm, the moment it comes out of, it starts from the moment you move out of wrist, it divides between superficial and deep branch. So another easy way of tracing radial nerve is to go to the radial artery. Again, we don't see anything clearly here. We see only tendons. So whatever we are seeing, it's tendon only next to the nerve. We don't see clearly any nerve. But if you follow the marker is lateral, so if you follow the radial artery, the pulsating structure, and trace it okay. So radial artery, if you are tracing, just we are not looking for any nerve. First we are looking for radial artery only. One muscle is becoming bigger next to that is the muscle brachioradialis. If I move again distally, it is becoming like a tendon. Okay, so that you have to look for that muscle next to the artery that is becoming bigger and bigger. The once the nerve that muscle becomes bigger, we see some component of so we all know the bulkier muscle which is in the lateral aspect is brachioradialis. That is what we are trying to see here along with the radial artery. So preferably if you want to scan, I have some difficulty in scanning the brachioradialis muscle. You have to keep the hand in the forearm in the mid prone position. Now you have to look for a brachioradialis. Now you can see some hyperechoic component. This is the radial depth, increase depth. Okay. So this is radial now. Now you can see almost two component it is getting divided, superficial and distal. The only point we have to remember is superficial radial nerve doesn't have any branches or any supply, sensory supply over the forearm. It supplies only in the below, beyond the wrist only. So that you have to keep it in mind. So if you want to have radial nerve effect, or if you want to have a sensation of this posterior cutaneous nerve, again I am stressing it, it has to be blocked above the elbow. So this is radial artery. The muscle component which is we are seeing bigger is brachioradialis. The hypoechoic component, what we are seeing is radial nerve. Here. Okay, so I think we have time for suprascapular nerve and posterior approach and axillary. Time is over. Okay, so I think in the scanning session, we'll try to scan suprascapular nerve and axillary nerve, which is not axillary brachial plexus, that we'll scan. So I hope I have done some justice. So if you have doubts, definitely we'll again discuss everything in detail in the scanning session. Thank you, Balaji.